Hello everybody, my name is Dr. Masumi. I'm a radiologist. I want to share you some of my interesting experiences about CT and MR images to you. In the first session, I showed you two cases, and in this session, I think you will be able to see two or three other cases about CT and MR images. So let's us to review the first one at this session. Yes, the patient was referred to the radiology department due to headache, and he had no other abnormalities of skin or GI or other systems of the body. The first image, as you know, is a T1 axial brain MR image, and I want you to see the image carefully to find abnormal finding. Maybe normal or maybe abnormal in these structures, but I don't show you abnormal finding in this picture, and take a guess please before continue to show the other slide. Yes, and the other image is T2 axial image. As you know, the differences between T1 and T2 MR images, one of differences is looking to signal intensity of the CSF or other fluids in the body or in that part of image. On T2 images, signal intensity of fluid such as brain uh, is bright. Here, notice please, this is T2 axial image. Signal intensity of the aqueous humor and CSF are bright, and this image is T2, and signal intensity of fluids in the T1 appears dark, such as here, or a low signal intensity. So this image is T1. Irrespective of these uh, picture characteristics, the next image of the patient is FLAIR image. What abnormal finding could you find? I think some of you took a guess, and may you notice about asymmetry of the picture, signal abnormality of right temporal lobe appear sometimes different with the other side, and may we find additional abnormality on axial images. Again, another hint about diagnosis on MR images is uh, accessibility of lots of sequences such as T1, T2, T1, T2, PD or proton density, FLAIR, and other images in different sequences in axial, coronal, sagittal, and other views. So in this patient, sagittal image of the patient is available, and you should guess about abnormal finding. Yes, and it's most important to use post-contrast study in some situations of brain CT and MR images, especially when we are dubious about known case of cancer when we are searching about complications, brain complications of known cancer, or in the brain MR images or CT images when we are suspicious to inflammation or to infection. These three important situations are need for post-contrast study: inflammation, infection, and known case of cancer. Yes, in this case, as you know, we should get a post-contrast study to obtain better diagnosis and to detect abnormal finding. And here, when this is shown, you can see abnormal finding very obvious. Yes, as you know, an abnormal signal intensity lesion is in close contact with tentorium here, and another one is in contact with sphenoid bone. And in review of axial images of the patient, you can see abnormal structure here and here. What are these? Considering signal intensity of the lesions on T1, T2 flare and post-contrast study, which show vivid enhancement as well as which demonstrate extraaxial location of the lesion, the finding is meningioma. And diagnosis is tentorial as well as medial tentorial as well as medial sphenoid ridge meningioma. This is an interesting case because when we have more than one meningioma in the brain, we could use meningiomatosis or multiple meningioma. When the patient have an underlying cause such as NF type 2, neurofibromatosis type 2, as you know, neurofibromatosis type 2 is a condition with multiple tumoral lesions of the CNS combined with other abnormalities such as skin abnormalities. In general, NF type 2 is a phacomatosis. In this patient, the patient was free of other abnormalities, so meningiomatosis is not indicated for diagnosis or not as an impression, and we should say multiple hemangioma. So in the finding of isolated more than one meningioma in the brain of a patient, term multiple meningioma is used, and when it takes place in the background of neurofibromatosis type 2, it could its name as meningiomatosis. Okay. We can review again from first image. Notice please, and correct your review of everywhere of the images. The next image, again about MR images of a patient who was referred to MR image, and the patient history is very important to put the diagnosis and to guess the impression about patient, and this patient was referred to MR image because she was a known case of breast cancer. So it's I think it's easy to find abnormalities. And as you know, here is an axial T1 image of the MR study. Abnormality is obvious somewhat here, as two nearby low signal intensity points, and also blurring of white matter and gray matter here, but not obvious. On on T2MR images, extensive edema around these two structures, which is disproportionate, is detected. Generally, when we are encountered with disproportionate edema around an MR brain lesion or more than one MR brain lesion, we should be highly suspicious about brain metastasis. And here in the background of edema, we could not find primary focus of the metastasis. The next image is flare. Again, is not helpful more than T2 in this case, but post-contrast study, as you know, demonstrate different picture of the primary image. Here, only two images were obvious. Were obvious with necrosis. This post-contrast study demonstrate a multi-ring structure with central low signal intensity and ring enhancement close to each other, or three nearby ring enhancing structures in the right posterior corona radiata, and another one is seen in the other hemisphere anterolaterally within same level, and you notice disproportionate edema compared with the primary images. Here the focus of METS, as I point in my speech, the patient is known breast cancer, and we could find brain metastasis. Yes, I said you primary lesions, metastatic lesions could be small, but edema around the lesions are very extensive and disproportionate to the size of lesions. When we are encountered to more than one lesion in the brain, one of most important differential diagnoses, especially if the patient is known case of a cancer or the patient age is high or old, metastasis or metastasis of tumoral lesion is one of the most important impressions. And as you know, in the breast cancer, about 10 to 15% of patients will develop brain metastasis, which has a poor outcome for patient. Its association with morbidity is high. Also, mean average survival of patient, as you know better than me, is about 4 to 5 months after diagnosis. And the other hint that I should say you is concurrency of brain lesions with primary lesion. Usually we expect to detect brain metastasis several months or even years after primary tumor detection in the breast. but sometimes it may be simultaneously, and in rare cases, first presentation of patient is with brain mets. Yes, the next or last case in this session is a pediatric case who was referred to radiology for long-standing abnormal bowel loop habitus and constipation. I think to be honest, I forgot about the history of patient, but the patient was undergo a barium study, and you can see here a case of pediatric with proximal distension of the bowel loop, and barium enema was down for him. In the lateral view, you can see abnormality very obvious. As you know, there is disproportionate size between rectum and the rectosigmoid, as well as proximal abnormal bowel loop distension with a narrow zone of transition here, and with serration of the outline of the involved segment of the rectum. And we were suspicious to yes, take a guess please. So we recommended the patients to refer in the 24-hour delayed for taking image, and this is AP image of same patient, and this is lateral view of same patient. Normally, as you know, after 24 hours of contrast study, if we take a contrast study of barium of large bowel, if we take another X-ray, usually we have expect to clear the bowel loop, expect for appendix. We expect to clear the contrast from the bowel loop in the normal situations or normal normal patients, sorry. But here you know that lots of contrast retention is detected in the bowel loops. So diagnosis is Hirschsprung disease. I showed you abnormalities here. Reverse rectosigmoid index, narrow transition zone, short segment of stenosis of the rectal area, and serration of these abnormal stenotic segment. As you know, Hirschsprung disease is usually seen in mature patient, and interestingly, it could not be seen in premature infants. And presentation of the Hirschsprung disease is usually in infancy, but it may present in late in the life. So we should down a contrast study for patient barium enema, but final diagnosis, as you know, is taking a biopsy of the submucosa of the rectal area or involved area. As you know, again, not only rectosigmoid but also the whole colon may be involved in some cases, and the disease has three types, especially or commonly short segment Hirschsprung disease is more common than other, and about 75% of patients have Hirschsprung disease short segment type. And another hint about Hirschsprung disease, as you know, and I say you is diagnosis by rectal biopsy to see a ganglion cells in the submucosa of the involved segment of the colon. Okay. And I think this session is enough to present some interesting cases and to hint some clinical or radiological points. So I finished the session or video here, and don't forget to subscribe me down here and put your suggestions down here in the comments, and I'm so thankful to sticking with me, and see you later. Thank you so long.